Today we are going to review the opiates, and those are by many standards called narcotics, but opiates are basically drugs that are derived from morphine. And I'd like to give you the critical features of their action, as well as the action, the toxic action of the opiates. So first we have to talk about pain because opiates are used for pain. And there are several different parts of sensing pain and registering in your brain that it is a painful event that's going on. So first you have, as we have in the slide here, we have nociceptor or pain receptors. Those signals then go up through the spinothalamic tract, which goes through the spinal cord, and that registers pain in your brain. And there's different regions in your brain. One is the cortex, and that basically is your perception of pain. But there's midbrain, like the thalamus, and there's other parts of the brain, like those places that control breathing. All are affected by the opiates. So let's get into this a little bit farther. Okay, so as you saw with those four, you've got basically sensing, transmission, registering, and then modulation. And the modulation is basically coming from the brain that alters the perception of pain. So in transmission, there's some important neurotransmitters that are involved, particularly at the dorsal horn. One is glutamate, and the other's substance P. And remember, there was a test or a question about substance P, and it's a peptide that's released as a neurotransmitter. Okay, so the modulation is a critical event. Opiates not only work in the brain, but they also work on this modulation event, okay? And it basically, the brain controls the input of pain sensing from the nerves coming from where the pain originates, and in many cases, there's an inhibition. So in a way that the brain is modulating that transmission of pain. And these parts of the modulation events happen at the dorsal horn, and this is where you have receptors that are receptors for the opiates. Now, opiates, the compounds that act to stimulate opiate receptors are not the morphine-like compounds. They are small peptides that have a similar structure as the opiates drugs themselves. So there's these opiate receptors that can modulate basically the inhibition, okay? Now, so the opiate receptors are threefold, okay? And these are receptors for endogenous peptides, which are endorphins and enkephalins, and there's three different types. There's mu, delta, or kappa receptors. And to some degree, that these relieve some of the acute or chronic pain. So you have endogenous substances that basically can be released that lessen pain, okay? And when we talk about opiate drugs, they're by far the most effective type of drugs for decreasing pain, for most intense pain situations, either chronic or acute pain. Okay, so opiates, those analgesics that modulate pain, are either a natural occurring compound like morphine, or semi-synthetic, mean the structure has been modified. And a good example of this is fentanyl, which is about 100 times more potent than morphine itself. So many of the opiates have come from the opiate poppy, like morphine or codeine, or others have been modified from those molecules and produce some synthetic derivatives. So opiates alter not pain itself, but the perception of the pain. And it does it at two levels, one at the level of the dorsal horn and the other in the CNS. Okay, so most of the receptors that are involved, the two most important receptors are the mu receptor and the kappa receptor. The delta receptor does modulate the effects of the opiates, although it has some of the effects that basically don't make you feel too well. Okay, so for the most part, we're talking about the mu and the kappa receptors, and where they're working is one in the brain and blocking the perception, okay, and the other is working on the dorsal horn and modulating or decreasing the effects that basically are the descending modulation. Okay, and this is one of the nerves that's actually affected by the opiates, and the receptors of the opiates are basically presynaptic, okay, and they modulate the effect of that presynaptic neuron and basically lower activity. So by stimulating opiate receptors on the presynaptic cell, they decrease the influx of calcium and then decrease the release of neurotransmitter, in this case glutamate, okay? And that's the main effect. And then the second one is to affect the postsynaptic cell, and they decrease the responsiveness to the glutamate, and that's through potassium channels. What you need to know is that the opiates decrease responsiveness. Now, we can attribute the different effects of the opiates to different receptors. One is, and we all know that the opiates are abused by many people, and this is because of the euphoric effect. And this is obviously in the CNS. We also know that opiates cause physical dependence. This also occurs at several levels. One is at the CNS. And all of these effects are modulated by the mu receptor. Now, on a negative side, and some of these are obviously negative, we've got respiratory depression. At a high enough dose, opiates shut down or decrease the drive to breathe, which is very significant, and it's always something that we have to worry about, particularly with people that are abusing opiates. And finally, the mu receptors are also involved in the dorsal horn or in the spinal thalamic tracts. Similarly, the kappa receptors are involved in many of the effects of the opiates, but one significant one is the pinpoint pupils or the meiosis that you see. But it also has to do with the sedation that you see from the opiates. And finally, the sigma has kind of different effects, the hallucinations, the dysphoria, respiratory stimulation. So in a way, we don't want to minimize those sigma effects, but they're not as important as the mu and the kappa. Okay, when we look at a person that's been treated with morphine or another potent opiate, we notice that there are other effects. One is that a number of different opiates are good anti-cough medication or anti-tussive. This is basically part of the effects on the brain, and not every opiate is the same. Codeine seems to be one of the better ones compared to morphine. Another effect of the opiates is basically decreasing peristalsis in the gut, and it turns out that the opiate receptor, particularly opiates that are very potent, stimulate the smooth muscle in the intestine to contract, but they do it in a random fashion, and so that you don't have peristalsis. They stimulate the gut, but nothing happens, and that basically stops you up. You also see effect on the parasympathetic system and decreased parasympathetic activity, and all of this ends up as constipation. Finally, there's effect on urination. That's through ADH, antidiuretic hormone, and there's also the meiosis. Okay, so other important things is that mood alteration, the euphoria or the not feeling so good, the dysphoria, the respiratory depression, that's primarily mu receptors. We've also got this emetic response, the vomiting response. That vomiting response is through the chemical trigger zone in the brain, and it causes a patient to vomit. And finally, I'd like to speak about the last one, the release of histamine. It's like an allergic reaction, but it turns out that morphine, having a basic structure like a base, it can take the place of histamine in the mast cell, and it's basically causing the mast cells to release histamine, but it doesn't take an antibody. There's no antibody involved. It's a direct release of histamine. So in certain sensitized patients, you can get a hives itching-like reaction just from the drug itself, no antibody. Okay, we know that tolerance is an important effect of the opiates, meaning as you give higher and higher doses, what happens is that you get less and less of a response. So most of the effects of the opiates, in fact, you develop tolerance to. There's a few that you don't see that. And the two that are the most important would be the pinpoint pupils, or the meiosis, and the constipation. Those you don't see typically tolerance to, but all of the other things like respiratory depression, like euphoria, the analgesia, you become tolerant to those, and it takes more and more drug to produce the effect. And so finally, to end this up, we did put up a video on week 3 lessons, and that you're all being asked to talk about. And this is rapid detox. And rapid detox is basically taking somebody that's addicted to opiates and rapidly detoxing them by giving them an antagonist. An antagonist has a very similar structure to the opiates, although it can go in and displace the opiate from the receptor and basically create this situation where you get rapid detox or rapid reversal of the opiate all in a very short period of time. And in those situations, they're using Narcan, but I must say that there's another drug called naltrexone that's also being used clinically to treat a number of different disorders, including alcoholism. It's typically not given IV, it can be given orally, and I will put up an article about that from the New England Journal and forward that to you. So I hope this video helps. Please let me know if I should continue to do this. Thank you very much.